We're here at the 10th conference on adverse drug reactions and lipodystrophy with Jackie Capeau, who is with the Pierre and Marie Curie Institute and the University of Paris Hospital 6. And you were co-chair of a session, the first session at the conference, and that was on the role of the role of fat and fat in all the wrong places.
Okay, this first session was related to fat, and so it was related part to adipose tissue and also to fat in the wrong places, and the wrong places are the liver and the muscles. And the first conference was interesting. It was given by Kit Peterson, working in Jerry Sherman laboratory in the States. And she explained that when you have some fat in the liver, steatosis, this will lead to insulin resistance. If you have some fat in the muscle, this will lead to muscle insulin resistance. And those two kinds of resistance are really important, in particular in diabetic patients, but also in aged patients. And you can move this fat out of liver, out of muscles. If you decrease the weight in obese people, you can decrease the liver in fat, and only in fat, and you increase the insulin sensitivity at the liver level. And if you want to move fat from the muscle, it will take a long time. It's possible. And in that situation, you are able to increase the insulin sensitivity at the muscle level. So this is a very important message to see, to think that fat in the wrong place is inducing insulin resistance. But if you have some diet intervention, exercise, and so on, you can decrease the fat in the wrong place and increase insulin sensitivity. And you know, insulin sensitivity is one of the key features leading to aging. And aging in HIV-infected patients is something really important, because it seems that those patients encounter something like a premature aging or a compressed aging phenotype, and you have to think about this insulin resistance, which is part of the picture related to the aging.
You know, it seems as though we talked about that from day one with AIDS, that AIDS seems to be like premature aging, or
it was not, just, I think this is quite a new thinking, because possibly for the people living with AIDS, it was something which was obvious, but not for the MD. And this idea went, I would think, in the last 2 years, thinking really about that. And in my lab, we have performed some cellular studies, and we're able to show that some drugs, some PI, third generation PI, but PI boosted with ritonavir, some NRTIs, stimulating analog NRTIs, are indeed able to induce premature senescence in cells treated on the long term. So this is something probably important. And in the same session, there was also 2 presentations of adipose tissue. And you say, okay, lipodystrophy, adipose tissue, we heard a lot of that. But the real new thing was in the 2 presentations, they tried to compare visceral fat and subcu fat. And as you know, in some of these patients with HIV-related lipodystrophy, there are some just opposite variation in the 2 fat depot with the subcu fat lipoatrophy together with a markedly increased visceral fat. So how to explain that? And this is very difficult, because it's very difficult to have some samples from visceral fat. So what was shown, and I would think this is really interesting and presented by Bénédicte Antoine, is that when you take fat samples from the 2 depots, from normal people, and you treat them with ART, you see that the subcu fat depot is highly sensitive to the drugs, and these drugs will induce an inflammation, increase IL-6 production, and this is seen only on the subcu fat and not in the visceral fat. And this could explain why subcu fat will decrease the fat storage, leading to lipoatrophy, and this is not the case for the visceral fat. So I think we begin to have some clues to understand why the 2 fat depots are just responding in opposite direction in response to the same drugs. And this is something new and important.
Did you find anything that would change, directly influence your sense of clinical practice, or is it just pieces? Did you?
I would think that something also very important is the inflammation. The inflammation story, a lot of people heard about inflammation, and it was said that this was due to the treatment. Some drugs were able to induce inflammation, and possibly this inflammation was part of the story, in particular the cardiovascular risk due to increased lipids, to increased endothelial dysfunction, leading to increased atherogenesis and to increase myocardial infarction and the cardiovascular risk taken as a whole. What is new is that is also the case from the HIV infection. Probably the virus could also induce a low-grade inflammation. And this low-grade inflammation is deleterious. And this was shown by the SMART study, because when stopping the treatment, even with a good number of CD4, you increase the viral load and you induce acute inflammation due to the virus, and this is deleterious at the cardiovascular level. So the new picture is that treatment could be deleterious, but ongoing HIV infection, even more. So you have to think not to stop the treatment, but probably to be very strict to control the virus. And I would think that the treatment is less deleterious than the infection.
Especially with the new drugs that are less...
And with the new drugs, because actually, really, the new NRTIs, even if the PIs are generally boosted with ritonavir, even when boosted, the toxicity is far less than the first generation PI and the timidine analog, the NRTI. So I would think that nevertheless, the treatment is less deleterious, and you have to control the infection to be sure and safer, at least safer, on the long term.
So the net benefit outweighs the net loss. And for that reason, you now believe and confirm your maybe beliefs to treat earlier.
Yes, and not to stop, and to be very aggressive on the treatment.
Is there any other take-home messages that you might have that pop out of your head at this point to let people know?
I think that things are really changing. I am really concerned by the aging. The fact that those patients are aging so rapidly and what to do. So I think we have to think how to be able to make something for the aging process. And also the other thing is that when the patients are aged, the number of comorbidities are increasing, and you have to be very careful with that. So we have to think that those patients have to be very carefully checked. They have to perhaps to have different treatment, to have to look for bone mineral density, to make a DEXA, which is not done, and the number of patients with osteopenia or osteoporosis is really increasing, and this has also to be checked. So you have to be very careful with the patient who are aging, and to take in charge all the comorbidities, and to screen for the comorbidities. And the other thing is that this is a whole panel, and this is really complicated. And it seems that something like inflammation is playing a leading role in all that. And possibly we have to think for new drugs, because there is a whole thing behind that. New drugs which could possibly have some anti-inflammatory properties, and which could help at least to decrease inflammation at the bone level, at the endothelial cell level, and the adipose tissue level, I don't know, and the renal level, and which could decrease these comorbidities and help the patients to have a safer health on the long-term aging processes with a very healthy aging.
Because we know we can live a long time with this disease.
Patients will live a long time, but you have to decrease the comorbidity to have a healthier aging.
Yes.
And you have also to think to very basic things. People are alone, people have decreased the social environment, and this is also some factors involved in aging. So people have to go out to have a social activity, to go exercise, to try to make the brain work. This is really important, because all these factors are really important against the aging. For example, exercise is a good protective factor against neurocognitive deficiencies. So you have to go away to have friends, to have social life, not to stay alone, and to be very active at the social level. And this also is quite unusual to be said, but helps against aging.
Well, you've been very helpful, you've been very informative, and it's very kind of you to take the time to work with us on this interview. Thank you.
Thank you. Bye.